Hi and welcome to this guide on functional endoscopic sinus surgery. What we're going to do here is to take you through the basic steps of sinus endoscopic surgery. I think for practical purposes we have divided this into 4 CDs. The first CD will concentrate on anatomy and physiology. The second CD will take you through clinical presentation and radiology and radiological anatomy. The third CD will actually get into surgery and cover it from uncinectomy to all the way to the ethmoids. And finally, the fourth CD will cover the sphenoid sinus, adjuvant surgery, complications. The reason that we have decided to come out with this CD with support from CIPLA is essentially that we feel that if your basics are good, if your basic understanding of anatomy and surgical steps is good, you not only ensure that the patient gets a good result, that your surgery is satisfactory for yourself, but also when you then tackle advanced surgery, you have a good core, you have a good support on which to build on, and it makes further surgery a lot easier. So with these few words, I think we get on and start with the talk. Hi, this is CD1, which is basically going to take you through anatomy and physiology, and we're going to update you on the way that we approach endoscopic sinus surgery at Bombay Hospital. So the different things that we will cover in this CD is embryology, anatomy, surgical anatomy, the variations of anatomy, and a little bit on physiology. When we talk of embryology, we're going to talk of all the different sinuses and the way they develop, its relevance to surgery. Why is embryology important? Is because of its relevance to surgery. And secondly, at the ages of which the development occurs, and this is important if you're going to be doing pediatric surgery. So embryology goes through 3 basic stages. The early prenatal stage, followed by the second stage which is chondrification and ossification of the nasal capsule, and finally you would get development of the lateral nasal wall. So in the first stage, the nasal placos will then form the nasofrontal process and develop into the nasal pits, which will then give rise to the lateral process or the nasal ala and most of the external nasal shape. And by the 8th week, your 2 nasal pits have now come from laterally fused into the midline. It then leads to the second stage. The initial part is the mesenchyme or chondrification, where chondrocytes and perichondrium cells will define the boundaries, will tell you what is the septum, what is the nose, what is the sinuses. And once that definition has occurred, then the osteocytes will lay down the bone after the blood vessels have formed the initial part of invagination into cartilage. Then you have multiple centers which will ossify and develop into the actual sinuses. And finally, the lateral nasal wall development occurs after 6 to 7 weeks. And you have core points. The maxillary turbinate will form, of course, the inferior turbinate and the ethmoturbinal, which will give rise to the different turbinates. The furrow between the maxilla and this ethmoturbinal will give the middle meatus, which will then be the opening for your anterior sinus cells. Later on, at 2 months and above, you'll have formation of the anterior part of the ethmoid, and then gradually, of course, you have growth of the sinuses, which for the first 6 years, even after birth, is slow. But by the age of 12 to 14, most sinuses have reached adult shape. So to take you through a few of graphical illustrations, we have first with the sagittal cut. We have over here the middle turbinate. This is a 140-day prenatal section. This you can see now is the ethmoid bulla right here. And between the two, you will have the sinus lateralis, which will form the retro and the suprabulbar cell. So you can see it will form supra and the retrobulbar cell, the areas. The nasoturbinal, which will give rise to the anterior part of the ethmoids, and the inferior turbinate sitting already inferiorly. We are now going to look at a 150-day prenatal with an axial section. You have the nasal septum in the center. On the sides you have the middle turbinates. Lateral to that you have the cleft that will lead to the maxillary sinus formation. In front of it will be the uncinate process. Just posterior to that will come the bulla, and then of course behind that will form the middle meatus, where maxillary sinus will open into. We are also looking at a coronal section here of a 160-day prenatal section, and here we see nasal septum, the crista galli on top. On lateral you see the fetal frontal recess, and one of these cells will then form the frontal sinus. You have the infundibular recess laterally, and here you have the nasoturbinal, which will form your turbinates. This being the inferior turbinate here, and this is of course the orbit, which will then give the nasolacrimal duct system. Right, so let's get a little more into detail. The infundibular recess is basically formed when you have an anterior superior expansion of this recess. You will lead to the frontal and the supraorbital cells. Occasionally this may even extend into the floor of the frontal sinus, in which case it will be known as a frontal bullar cell. Very rarely it may even lead to formation of the frontal sinus itself. Of importance is the fetal frontal recess that we saw in the earlier section, which consists of 2 to 4 cells, and some of these or one of these cells will lead to formation of the frontal sinus and the ostium. The remaining cells will then often lead to formation of frontal cells or form part of the anterior rhythmoid. We will also have formation of the upper part of the uncinate from the FFR. At about 2.5 years, the frontal sinus development has reached the superior aspect of the nasion and is definitely identifiable. When we talk of the anterior rhythmoids, it develops from the same frontal recess furrow and includes the upper infundibulum, the suprabullar space and the infrabullar space. The posterior rhythmoids will develop from the superior and the supreme meatus, and even after 4 weeks you have a definitely identifiable rhythmoid bulla. The maxilla, when we saw in the axial section, even at 2 months there is pouching, the lateral outpouching of the nasal mucosa from the infundibulum, and that will gradually become bigger, and at term the maxillary sinus is quite small, it's in millimeters, but majority of the growth will occur only after secondary dentation, when the teeth have descended, and then the maxilla is free to grow into its full size. The sphenoid is probably the most important sinus developmentally, and most of the major progress of man, as we see from the early days, is been in relation to the sphenoid. So as the sphenoid is developed, man has evolved, has progressed. And this sinus is the only sinus not to arise from the lateral sinus wall, but from the cartilaginous aspect of the nasal capsule. It develops in 2 parts. The initial part being the anterior wall from the sphenoid primordium and the sphenoid conchae, which forms the surrounding cartilaginous wall, and the second part is from the skull base portion posteriorly coming anteriorly. So that takes us very briefly through the embryology and how it can influence or changes or variations in the anatomy of the nose. And that also explains why the frontal sinus, being the last sinus to develop, is a large sinus, but the drainage pathway is very narrow, because the drainage pathway only occurs after the ethmoids have taken place, or the relation of how you may have more than one frontal sinus cell depending on which frontal furrow cell has formed the frontal ostium. When we come now to nasal anatomy, we are going to be talking of all these different aspects in the nose. We are initially now going to talk of the middle turbinate in the anatomy, because this forms the most important structure endoscopically, and the core and the landmark around which all your other anatomy is then based. So when you look at the attachments from anterior to posteriorly, the initial attachment is at the upper part and the anterior part of the ascending process, the frontal process of the maxilla, and also forms the posterior part of the medial edge of the agar nasi. So it sort of tends to go up and turn laterally in the anterior lateral part of the nasal wall. It then attaches to the roof in a parasagittal plate at the junction between the medial and the lateral cribriform plate. At some point it then turns laterally and will attach to the lamina papyracea to form what is called the ground lamella in the coronal plane. And what this does is divide the ethmoid into anteriorly the anterior ethmoids and behind the ground lamella into the posterior ethmoids. And finally the middle turbinate will go posteriorly, again turn a little horizontally and attach to the posterior lamina and the ascending process of the palatine bone in the axial plane. There are various variations to this, not only the middle turbinate but the other turbinates. The pneumatizations can occur. If it occurs in the basic turbinate itself, it's known as a concha bullosa. If it occurs in the stem, it's known as a lamella bullosa. Superior turbinates are often pneumatized. Inferior turbinate is very rarely pneumatized. Posterior septum again is not infrequent. Some of the examples here you can see is a large concha bullosa on the left side, and you can see the same concha bullosa here on the CT scan. Also a very large concha bullosa on the right side. You see here below that a concha bullosa of the superior turbinate, and over here you see what is called a lamellar concha bullosa. So the turbinate itself is not really pneumatized, but the lamella of the middle turbinate has been pneumatized to form a lamellar concha bullosa. This CT scan shows pneumatization of the posterior end. You can see that the posterior ethmoids are still present here. So this is pneumatization of the posterior end of the septum, and this will then of course lead into the sphenoid sinus. Coming now to the lateral nasal wall, we look at the uncinate process. The uncinate process is sickle-shaped bone that is attached to the lateral nasal wall. It's fixed anteriorly and has a free posterior border, and the attachments are variable. All of you are familiar with this diagram that tells us that the uncinate may attach to the bulla or may go in conjunction with the bulla to attach superiorly to the orbit. It may occasionally be attached to the skull base, and very rarely it can be attached to the middle turbinate itself, in which case of course the importance is that the frontal recess, the frontal drainage, in this case when it's attached medially, the recess and the drainage is then laterally, whereas if the attachment is lateral, then the drainage is medial. So this is an example of one of a CT scan showing the attachment of the uncinate to the ethmoid bulla and then curving laterally, so you can see that the drainage pathway is medial. Similarly on the left side. Right, so talking now of the uncinate and its relationships, why is the uncinate important? Just behind the uncinate is the hiatus semilunaris, or a semilunar opening into the infundibulum. So when you look at this figure, you see that the Tobey's forceps is now, this is the uncinate process, and the Tobey's has just entered the hiatus semilunaris, this being the middle turbinate. If we were to rotate the Tobey's laterally, we can see now that this is disappeared, and this is now entered the infundibulum, which will then lead into the openings, where the openings of the frontal anterior ethmoid and the maxillary sinus will come. This is also now, you can see very clearly, the free edge of the uncinate process. In the inferior part of the uncinate process is the opening of the maxillary sinus, and unless you remove this inferior process of the uncinate, it is extremely difficult to see the maxillary sinus, the natural opening of the maxillary sinus. You may occasionally see a posterior accessory ostium without doing any uncinectomy, but to see the normal opening, which is anterior, you need to remove, then go down with the uncinate all the way to the upper part of the inferior turbinate to where it is attached. Occasionally it may be pneumatized, the uncinate itself, as you can see in the CT scan on your right side corner. Sometimes the uncinate may be atelectatic, it may be atrophic, and in that situation it is then a little more difficult to do an uncinectomy, being lateral. If however there has been a lot of disease in the maxilla and has pushed the uncinate outwards, the uncinate then becomes medialized. And that is a far easier situation where the uncinate looks something like this, medialized, and often known as the double turbinate sign. This is a video of the uncinate process, showing on the left side the middle turbinate, which is just gently retracting, and that brings into vision the entire uncinate process. This is the anterior part of the uncinate process, where you would normally incise to do an uncinectomy. Just behind is the ethmoid bulla and the free edge of the uncinate process. Coming now to the maxillary sinus, the size is quite large. Both the sinuses are usually symmetrical. You have not only the natural ostium but also accessory fontanelles, usually the posterior fontanelle, which may form an accessory ostium. You must remember that the cilia flow is always towards the normal ostium, which is in the superomedial aspect of the sinus. You occasionally may have intersinus septae, and again sometimes you may have a Haller cell, which is an ethmomaxillary cell, part of the ethmoid complex, which can come into the floor of the orbit and obstruct or reduce the opening of the maxillary sinus. So in this figure you see a largened maxillary sinus, and you can through it see the infraorbital nerve. Right, so the size of the maxilla in the adult patient is almost 3 by 2 centimeters. In 5% of patients, the maxillary sinus may be hypoplastic, in which case again the uncinate will be lateralized and may make surgery a little more difficult. You may also put the orbit at risk. So these are things that you need to see in your CT scan. The sinus ostium is quite variable, being averaged about 5 millimeters in size, and the uncinate covering the inferior part of it. And again remember, the anterior and posterior fontanelles are usually covered by membrane but occasionally dehiscent, leading to accessory ostia. This figure shows us the mucociliary flow as it would from the lateral part towards the normal ostium. And this is the reason why doing an inferior meatus antrostomy did not work. Because in the presence of cilia, the flow of the mucus would always try and get the mucus to exit from the natural ostium and not from any artificially created openings. The variations of the maxilla, apart from being hypoplastic, is that in about 10% of patients the fontanelle will be deficient of membrane, as you can see in this figure, and the accessory ostium will then appear. Occasionally you can have intramaxillary sinus, and in the CT scan you can see the presence of a Haller cell. This is what is called a Haller cell, which can narrow the opening of the sinus ostium. Coming now to anatomy of the frontal sinus, the size is very variable, from being unformed or hypoplastic to an extremely pneumatized frontal sinus. The two sinuses are usually asymmetrical and will have a lot of interfrontal septae, giving the bossylated appearance. The ostium of the frontal sinus lies in the infero-posterior part of the sinus itself and drains either into the medial or the lateral aspect of the frontal recess into the nose. It can be complicated, the drainage pathway, by the presence of frontal cells and or other additional cells such as the interfrontal septal sinus cell. In this figure you see the frontal sinus, you see postulation of the anterior cranial fossa, and you see the frontal recess. So when we talk of some of these details, the interfrontal septum usually starts off in the center and then deviates to either one side, leading to two completely different or asymmetrical frontal sinuses. The diameter of the anterior wall, which is a lot thicker, is about 4 millimeters, whereas the posterior wall is a lot thinner usually, but occasionally can be thick. This also explains why complications of the frontal sinus usually tend to go more through the posterior wall as compared to the anterior wall. The ostium lies in the posterior medial, as we've already discussed this, and the size may range from being extremely tiny to about 7 to 8 millimeters. The frontal recess itself is only an hourglass shaped passage between the frontal sinus ostium itself and the ethmoid sinus, the anterior ethmoid sinus. Occasionally this frontal recess was extremely narrow due to the presence of the agar nasi and frontal sinuses, and led to the, instead of being hour shaped, led to the formation of a tubular structure. And so erroneously, in the past, we used to think that there is the presence of a frontonasal duct, whereas actually it was only a tubular long frontal recess. Variations of the frontal sinus may be from being completely, there being no development of the frontal sinus itself, to a very pneumatized frontal sinus. Very rarely there can be a duplicated frontal sinus, and there's one article which even says there were four or five frontal sinuses. If there is development of one of the frontal fetal recess cells into the frontal sinus, then you can have formation of the frontal bulla cell. And of course we'll discuss this in detail when we talk of frontal cells and how we differentiate frontal cells as in type 1 to type 4. The interfrontal septal sinus cell is also a different variation. This figure shows us the drainage sinus, the frontal sinus drainage pathway, and you can appreciate here that this is the frontal sinus, this is the agar nasi, this is the type 1 cell, we have a supraorbicular cell, and how the frontal sinus drains between these cells into the infundibulum, and from there into the middle meatus. So we are now looking at the frontal cells. These are divided into K1 to K4 cells, depending on their position and their number. What we have to remember is that there is only one agar nasi cell. Any cell additional to that one agar cell becomes frontal cells. So if you have one cell which lies above the agar cell but under the vertical aspect of the frontal sinus, which is basically below the nasion, it then is called a K1 cell or a type 1 frontal cell. If you have more than one cell in relation to the agar, but again below the vertical ascent of the frontal sinus, they are then known as K2 cells or type 2 frontal cells. If any cell were to ascend into the vertical aspect, vertical table of the frontal sinus, it then becomes known as a K3 cell. And if you have a cell which is isolated in the frontal sinus or rises more than 50% of the height, the vertical height of the frontal sinus, it is then known as a type 4 or a K4 frontal sinus cell. Another variation is known as the interfrontal septal sinus cell, when you have a cell which is attached to the septal sinus, and if you were to follow it backwards, it would then open into either independently into the recess or into the frontal sinus. So you see here this cell on the coronal section attached to the septum. On the sagittal section you will see rising above the agar cell, and again on the axial section lying between the two frontal sinuses. So now we come to a discussion of the anterior ethmoid sinus. The anterior ethmoids can be hypoplastic to being extensive, but not as variable as the frontal sinuses. Number of cells, however, can be variable, from a few cells to even 12, 13 cells. The lateral recess will then form the retro and the suprabullar recesses. The part which is above the bulla will form the suprabullar recess, and the part that is behind the bulla, between the bulla and the ground lamella, will form the retrobullar recess. It is related, of course, strongly to the orbit and the optic nerve, amongst other things. The ethmoid bone itself, the primary ethmoid bone, consists of a perpendicular plate which forms part of the septum and then rises vertically to form the crista galli. At the roof, it then becomes a horizontal plate forming the cribriform plates, the medial cribriform and then the lateral cribriform plates, and then laterally under the ethmoid fovea it will form the ethmoid labyrinth. The ethmoid labyrinth itself is a quadrilateral prism with a narrower front and a wider, broader base posteriorly. The number of cells, as we mentioned, is variable, and the entire ethmoid is related to the orbit laterally, the middle turbinate medially, the frontal superiorly, which forms the fovea ethmoidalis, and the optic nerve and the sphenoid posteriorly. What is important is that the roof of the ethmoid, or the fovea ethmoidalis, the bone is a lot thicker, about half a centimeter in size, about half a millimeter in size, as compared to the cribriform thickness, which is 1/10 of the thickness, and therefore far more liable to trauma during surgery and or in complications or in head injuries to being fractured. Coming to the ethmoid labyrinth itself, the agar nasi is the anteriormost of the ethmoid complex and is closely related to the middle turbinate and the uncinate bone, and lateral to it is the lacrimal bone. Just behind the uncinate process is this three-dimensional space known as the hiatus semilunaris, which is a semilunar space and leads towards the ethmoid infundibulum, and the infundibulum is a drainage pathway for your anterior group of sinuses. The ethmoid bulla itself is the most prominent of the anterior ethmoid cells, and above which will be the anterior ethmoid artery. Lateral to it is the orbital lamina papyracea, and posterior to it will come the ground lamella and occasionally the retrobulbar recess. There may be, in relation to the bulla, many more cells, being the supraorbital cells and or the frontal cells, and posteriorly, of course, will come, in relation to the posterior ethmoid, the sphenoid, and you may have a sphenoethmoidal cell known as the onode cell. So these are some figures to show you just the ethmoid anatomy. You have, in this first cut, you see the middle turbinate, and you see just the first view of the ethmoid bulla. When we go in closer, you see the ethmoid bulla a lot better, which is attached laterally to the lamina papyracea. Posteriorly, you can see how the middle turbinate is turning laterally to form the ground lamella behind it, and between the ethmoid and the ground lamella will be the retrobulbar recess. We have now made an opening into the ethmoid bulla to show the interior of the ethmoid bulla, and then we have removed the upper part of the ethmoid bulla to show the ground lamella behind it. When we look at the agar nasi cells now, we see this CT scan showing well pneumatized agar nasi cells, very large agar nasi cells, and these are some frontal cells in relation to the agar nasi. So you don't have 1, 2, 3 agar nasi cells. You have the anteriormost lower cell being the agar nasi cells, and the cells above the agar being, in this case, type 2 frontal cells. You can also see at this stage that the middle turbinates have yet not appeared in your view. So you know that the agar starts just in front of the middle turbinate, and you just see the start of the maxillary sinus. So when we talk of the anterior ethmoid artery, the vasculature in the ethmoid, one of the most important vessels, the anterior ethmoid is actually a branch of the internal carotid artery, which leads to the ophthalmic artery, and terminal branch of the ophthalmic artery, which exits the orbit. From the orbit, it exits at the frontoethmoid suture, runs across the roof of the anterior ethmoid cell usually in a bony canal, and passes through the olfactory groove floor in the anterior base of the crista gali, goes intracranially, curves around, and then re-enters through the cribriform into the nose to supply the nasal septum. Posteriorly, you have the posterior ethmoid artery, which is not usually as prominent or as well seen as the anterior ethmoid, and occasionally you may have more than one branch. And this is also emerges from the orbit at the frontoethmoid suture, and in about quarter of our patients, about 25%, it may be not seen. So just to take you through a quick video here, you're in the left side of the nasal cavity, lateral wall, middle turbinate here. This is the anterior ethmoid artery, the upper part of the ethmoid complex, above which is the frontal recess, above which is the frontal sinus. So this really gives you a very good idea of anatomy and the relations. Anteriormost and superiormost is the frontal sinus, below which is the frontal recess, below which is the anterior ethmoid artery. And if you're ever lost, then either you can find the anterior ethmoid artery and trace it upwards and anteriorly into the frontal sinus, or if you know what the frontal recess is, you know at the floor of the frontal recess, you're going to find the anterior ethmoid artery and prevent damage and bleeding to this anterior ethmoid artery. So this is another figure that shows us the frontal sinus above, a couple of suprabulbar cells which are still present and need to be removed from the frontal recess area, and under which is the anterior ethmoid artery. Here would come the ethmoid bulla. Right, so now we come to the posterior ethmoid sinuses, and again the posterior ethmoid, usually the cells are larger, less in number, and being in relation now to the sphenoid posteriorly and the ground lamella anteriorly. Occasionally we have what is called an Onodi cell, and you can see it beautifully in this sagittal section, where you see the posterior ethmoid extending beyond the anterior wall of the sphenoid sinus, and also, and then in that case it becomes very closely related not only to the optic nerve but occasionally even to the internal carotid artery. And it has to be kept in mind not just to prevent inadvertent injury to these structures, but also not to confuse it with the sphenoid sinus itself. So in the posterior ethmoid you have usually 2 to 4 larger cells as compared to the anterior ethmoid with multiple smaller cells. You may have incomplete septations. If you have a supreme turbinate, you then have a supreme meatus, and usually one of the posterior ethmoid cells will then open into this supreme meatus posteriorly. You must remember it's related closely to the optic nerve and the carotid artery, especially if there's an Onodi cell, and it lies superolateral to the sphenoid. The sphenoid in relation to the ethmoid is inferomedial. So to open into the sphenoid you must go inferiorly and medially, whereas if you go in a straight line and continue superiorly, you're then in the posterior ethmoids. So an axial scan here, just to show you again anatomy. Anteriorly you have the agar and the anterior ethmoid group of cells. You have the ground lamella, and then you have in this case 1, 2 and 3 posterior ethmoid cells on the left and 2 large posterior ethmoid cells on the right. You also see the relation of the optic nerve in relation to the posterior part of the lateral part of the posterior ethmoid cells before it becomes again closely related to the sphenoid sinuses. When we talk of relation to the sphenoid wall, again an endoscopic picture that shows us very clearly how the posterior ethmoid, which is all this part, is superolateral to the sphenoid anterior wall, which is inferomedial to the posterior ethmoids. This being the right side, middle turbinate, and the orbit, which will come over here. So going further back from the posterior ethmoids, if you continue in the same plane going posteriorly and superiorly, you're certainly not going to enter the sphenoid cavity, but you may enter the intracranial area. So you must remember to come medially and inferiorly, and this is then the sphenoid wall, which lies in a more vertical plane as compared to the posterior wall of the ethmoids, which tends to go away, so as to say, and be more conical or pyramid shaped as compared to the straight flat sphenoid anterior wall. There are lots of variations in the sphenoid, in the ethmoid, some of which are here. There are suprabulbar cells, maybe one, maybe more. Occasionally a suprabulbar cell may extend to the frontal, forming the frontal bulbar cell. You may have it extending above the orbit from the frontal recess, forming the supraorbital cell, again often confused with the frontal sinus itself, and one must be aware of these cells when you're operating. The bulla itself may be well pneumatized, which is usually the case. Very occasionally it may be hypoplastic, in which case known as a lateral torus. Haller cells are infrabullar, infraorbital cells, which tend to almost come in towards the maxillary sinus. And posterior lateral you can have the sphenoethmoidal cell or the Onodi cell in relation to the sphenoid and the optic nerve. So to show you some illustrations of these cells, you have, when you have this is the bulla, and when you have a suprabullar cell in relation to the skull base extending into the frontal sinus, not to confuse it with a frontal cell which would come more anteriorly. This is in conjunction, on contact with the bulla, but it extends into the frontal sinus, and on a coronal scan may often be mistaken as a type 4 cell. And this very clearly demonstrates again the importance of having sagittal cuts, or having cuts other than just coronal cuts. So as to clearly define where your cell is going to be, and instead of going and hunting blindly for the cell, you know this to open into the suprabullar area. So this is a frontal bullar cell. Laterally, and this is something that all of you are familiar with, is a supraorbital cell. So you have a cell that rises laterally above the orbit, more lateral to the frontal sinus, which will come medially and superiorly and more anteriorly. And the opening of this suprabullar usually is posterior and inferior to the opening of the frontal sinus. This is what it looks like on a sagittal cut. And finally, talk of suprabullar cells. All cells above the bulla, in conjunction with the skull base, are suprabullar cells. You may have one cell, as you can see here, or you have multiple cells. Again, an illustration to show you what an Onodi cell looks like. This is a widely open Onodi cell, and you see here in this opening of this cell the optic nerve running across, and this will then form the anterior wall of the sphenoid sinus. Again, remember, it's inferomedial. This is the posterior wall of the lamina papyracea and the orbit, and this is the pneumatized sphenoethmoidal cell, under which here will come the internal carotid, which will of course in this case see better once we open the sphenoid sinus. So coming to the sphenoid itself, the size of the sphenoid again may be very small, what we call a conchal sphenoid, to a very extensively pneumatized sphenoid going above the lateral pterygoid plates, laterally above the pterygoid plates. Again, the sphenoid septum itself usually starts in the midline of the rostrum and then turns off to either one side, giving rise to asymmetrical sphenoid sinuses. You additionally can have intrasphenoid septae, then having incomplete septae dividing the sphenoid into further partitions. The ostium of the sphenoid in the anterior wall of the sphenoid lies in the superior aspect of the anterior wall, about 1.5 centimeters above the upper edge of the choana in relation to the nasopharynx. It also is related very well to the superior turbinate, as you can see in this diagram where we lateralize the superior turbinate. So if you stay in the inferior half of the superior turbinate, then that's where you're going to find the sphenoid ostium just lateral of the nasal septum. The sphenoid is related closely to the optic nerve, the carotid, and if it's extensively pneumatized, to other cranial nerves. Also, it provides a route of approach to the sella. The sphenoid itself is identified well in the 4th year, being a little hypoplastic at birth, and growth continues well past puberty. Intersinus septums, as we mentioned, usually deviate laterally, and of importance is that the optic canal is prominent in 40% of patients, and a high percentage of these patients will have thin bone, which is less than 0.5 millimeters. In 4% of patients, there will be no bone at all. You have what is known as bare optic nerves, and these are the situations where complications of the sphenoid sinus can occur. The carotid canal also, according to Stamberg, in about 40% is biologically dehiscent, which means the bone is thin enough that it can fracture easily, and therefore, especially in the part of the cavernous area, is where you get a little reddish blush, and you have to be a little careful not to instrument in this area. So to show you the actual cut of a CT scan here, and you can see the sphenoid sinus in relation to the posterior erythmoids, you see the optic nerves in relation to the sphenoid. You also see how the ostium opens in the medial aspect into the sphenoethmoidal recess, and how the septum deviates laterally, in this case deviating towards the optic nerve. So there are some variations of the sphenoid. Basically 3 variations regarding the pneumatization, which again I'm sure all of you are familiar with. There is the conchal, the precellar and the cellar variations. In the conchal variation, the sphenoid is extremely hypoplastic, and only in about 2 to 3%, fortunately this is rare, only 2 to 3% of patients have a conchal development. Precellar is when the anterior half of the sphenoid is well pneumatized right up to the cella, but not the pneumatization does not extend beyond or into the floor of the cella, is then called precellar, which is about 10 to 24%, whereas most of the sphenoids are cellar, where the entire cella, including the entire floor, is well pneumatized, and this is in the majority of patients. Occasionally, even in the same patient, the pneumatization in the sphenoid may be asymmetric. So you could have a cellar on one side and a precellar pneumatization on the other side. And very rarely is the entire sphenoid just one cavity, because the intersphenoid septum has either been deviated so laterally or is not existent. The other sinus is not developed well. So to show you the pneumatization, this is a conchal pneumatization with just the anterior part of the sphenoid pneumatized and a thick bone here between the posterior part of pneumatization and the anterior part of the cella. Then you have the cellar pneumatization, where you have the anterior part of the cella which is pneumatized, and you have cellar pneumatization, where the pneumatization continues into the floor of the cella and it's extensively pneumatized right up to the posterior part of this. And this is where a majority of patients belong, and why it's a lot easier to do cellar surgery. Coming finally from anatomy to physiology, what is the role of the turbinates? How do they help? And of course, we know that airflow in the nose must be streamlined. There must be a lamellar, a nice homogeneous flow, not a turbulent flow of air, which would happen in patients of atrophic rhinitis. So turbinates not only help in providing some resistance, but also directing airflow and giving additional mucosa for humidification and warming of the air. In addition, when we're talking of, like in this situation of surgery, the turbinates form one of the cornerstones, one of the key landmarks based on which all your other surgery occurs. So not just from an anatomical but also a physiological point of view, you do not want to cut turbinates unnecessarily, you do not want to remove turbinates unnecessarily, you want them to remain there to provide you physiological and functional support. Only then can you say your surgery is functional endoscopic sinus surgery. The uncinate itself also is another important factor which we tend to remove during surgery. And what the uncinate tends to do is that it directs the airflow when you breathe in. It directs the airflow posteriorly, and the exhaled air is then directed by the uncinate into the middle, into the infundibulum and into the sinuses. So the air that enters the sinuses is exhaled, purified or filtered air, and not direct air from the inspiration, which contains a lot of host of allergens and potential pathogens. So again, when you remove the uncinate, you're now allowing inspired, unfiltered, unsecured air to enter your sinuses, and there is again a lot of thought to trying to preserve the uncinate. In most situations this is not possible because the rest of the surgery is difficult unless you do an uncinectomy, but from a physiological point of view one can understand the importance of the uncinate process. The mucosa of the nose is pseudostratified ciliated columnar epithelium, and therefore it contains cilia which will always genetically programmed to be towards a normal ostium. You cannot change this genetic programming. So making accessory or artificial ostia opening in any of the sinuses is unphysiological, is against the dictates of what you have been born with, and therefore all surgery must be performed to facilitate normal drainage. So your normal ostia must be widened or increased in size, and only then is your surgery physiological or going to work effectively. Finally comes smell. Smell is one of the most important aspects of anyone's life, far undervalued and understated in the human species, but it's only when it's lost that you really understand the importance of smell. What is smell important for? Of course, to a lot of people it means food, and food is life. Without smell there is no taste, and the whole quality of life is affected. But also from other aspects, appreciating good smells, perfumes, the warnings of danger, of smoke and fire, all that is lost when you don't have smell. So again, in patients like with polyposis, with mass in the nose, you have lost smell, and you must try and restore the smell as far as possible without actually causing damage to olfactory fibers. We see here in this diagram actual olfactory fibers in relation to the cribriform plate here. And as far as possible, when you are doing surgery, we try and stay away from damaging olfactory fibers, even if it means occasionally leaving a little bit of polyp behind, so as not to permanently damage the sense of smell. And I assure you that patients who have some sense of smell are going to be far more grateful to you than those in which there is a great passage but no sense of smell. So this really brings us to the end of CD1, where we've gone through anatomy and physiology. Thank you.